This is a degeneration of the upper and lower motor neurons. My favorite coach in middle school, Coach English, God rest his soul, he had amyotrophic lateral sclerosis, or ALS. And it was just so heartbreaking to see his body degenerate or break down from this disease. The etiology is idiopathic, so we don't know what the true cause is, but there is some suspect that it is a genetic mutation. When we look at this, the survival rate is about 3 to 5 years once diagnosed with ALS. And only about 5 out of every 10,000 people end up with ALS. So the likelihood or the epidemiology is relatively low, but the downside is survival rate is only about 3 to 5 years. So when we see this, we're going to see that these patients will present with weakness or that instability in their gait, in their walking. Remember, we saw this with myasthenia gravis as well. You're going to have bulbar or swallow impacts or implications. You're going to have dysphagia or dysarthria, which is difficulty with speech or even difficulty chewing. So that bulbar findings, these are all associated with swallowing. And remember, dysphagia is associated with difficulty swallowing. So we're going to have these patients that ultimately end up with diaphragmatic involvement. That's going to lead to some shortness of breath, and an inability to clear their secretions, and ultimately respiratory failure. I remember Coach English, he was such a lighthearted man. He was so great, and it took a lot for him to get irritated. It took a lot for him to actually get mad. But he used to tell the students that when he gets really mad, he would levitate. And he had this electric wheelchair that allowed him to get from place to place so that he could continue to work. But when he would get mad, he would hit a button and the entire wheelchair would actually lift. So it was a way for him to continue to keep his lighthearted and humor with this debilitating disease. So there's not a specific diagnostic test that says, oh, this patient has ALS. I can't do a specific blood draw and get a specific marker that tells me that this patient has ALS. We're going to do this through evidence of lower motor neuron degeneration and evidence of upper motor neuron degeneration. It will progressively spread, and you will end up with identifying these during your clinical examination. So when we look at the specific electrophysiologic testing and the neuropathologic exams, we can use nerve conduction studies. So the EMGs are typically tests that we can look at, or even nerve conduction studies. We can even look at the MRI of the brain and the spinal cord so that we can exclude other disorders. And we can even do a muscle biopsy. These are routinely performed with patients with ALS. But may be performed to exclude other diagnoses like myopathy. And so we look at a number of different diagnostics when it comes to ALS. Some telltale clinical signs that's associated with it is sialorrhea or excessive drooling, and we can end up with tongue fasciculations, and we talked about that before. When we look at the treatment, there is ultimately no treatment or cure for ALS. We can look at utilizing Riluzole is a medication that slows the progression of the symptoms, but ultimately these patients are going to succumb to the ALS. What do we do as respiratory therapists? How do we manage this? These patients are going to need some assistance with coughing, whether that's a cough assist, whether that's working with them with their incentive spirometry or MIP or maximum expiratory pressures. We can look at airway clearance devices, and we're going to continue to monitor their respiratory function. So when we look at monitoring the respiratory function, what we're doing is we're identifying when it's time for that patient to ultimately go on mechanical ventilation. We're going to do that as a supportive therapy. We're going to make sure that airway clearance therapy is to assist with any of the cough or improve airway clearance of secretions. and to reduce any incidences of pneumonias. Management of other conditions like insomnia, depression, pain are also important. These patients should have discussions about their goals of care and when advanced directives should be considered for these patients, and potentially going to hospice or palliative care. So it's a tough disease once diagnosed, but we can do things to help extend their quality of life, but ultimately these patients will succumb to the disease.